Hello and good evening, everyone, and a very warm welcome to this insightful digital symposium hosted by Veiva Scientific in collaboration with Abiomed. We are honored to have all of you here with us today, and we are going to discuss this very important topic of managing complex PCI with Impella. Before we begin, I would like to extend my gratitude to our esteemed panel of guest faculty, speakers, and expert panelists for taking time out of their busy schedule and sharing their knowledge with us today. It's Viva's privilege to host such great physicians from both India and abroad on this platform. We have with us today Dr. Benedict Schrage as our guest faculty and speaker. Dr. Schrage is a renowned cardiologist and senior physician at University Heart Center Hamburg. With a PhD in heart failure therapy, he has received prestigious awards like the Young Investigator Award from the European Society of Cardiology. His expertise spans in advanced cardiac care, clinical research, and device-based therapies, making him a respected figure in cardiovascular medicine. Thank you, Dr. Schrage, for joining us in this session today. And now to guide us through the session, we have the pleasure of having our expert panelists, Dr. Ajit Menon sir from Sir H.N. Reliance Hospital, Mumbai, Dr. A. Srinivas Kumar sir from Apollo Hospital, Hyderabad, and Dr. R.K. Jaswal sir from Fortis Hospital, Mohali. Also, Dr. G. Sango Chuvelu from Apollo Hospital, Chennai is going to join us shortly. Once again, I would like to thank everyone for joining us this evening. And I would now like to hand over this platform to our expert panelists and take forward this session. Dr. Srinivas sir and Dr. Jaswal sir, I would really like you to take this forward.
Yeah, good evening, friends, and thank you for making this possible for all the doctors in India. It's really very interesting and very important device which all of us should become comfortable with, especially when you're dealing with very complex PCI chip type of procedures. And it also comes to a lot of help in dealing with acute MI, ACS type of scenarios, with cardiogenic shock scenarios. And we'll learn more and more about it. And now we are happy that it is under new company's forwardship, and hope it will be accessible to more and more number of patients. And we wish that it will become further cheaper so that it could be used for more number of patients. But we have a lot of learnings happening, and the recent trial showing positive things, lot of interest in this. And we are eagerly waiting to hear from the expert speaker and also share some experiences. I will be showing some case of acute ACS, acute MI, and others will be showing their experiences. With this, I request my other co-moderators to say a few words before we go on to lecture from international faculty. Over to you. Hello, did you hear me?
Yeah.
Jaiswal sir, over.
Good evening, Dr. Jaswal.
Good evening.
How are you? Good?
Fine, fine.
Yeah.
Good evening also from me.
Yeah. Hi, good evening. So this will be an interesting evening. We are going to see PCI support, Impella supported PCI. So I think this has really given us a lot of confidence in doing the complex PCI nowadays, because there are many patients who are surgical rejects. They're in bad shape. They are not sustaining on advanced life support, and we have to do something. I always call them, these are hopeless patients to which we provide hope by doing complex and complete PCI with the support of Impella. So I think over the last few years, we have gathered a lot of confidence in doing these patients, particularly where the hemodynamics are very, very unstable and the LV function is poor. There, you are quite skeptical about doing interventions, because what we observed about 2 decades ago was with IBP, closure used to happen. So the basic advantage with Impella is, that there are very few episodes of hypotension. It maintains circulation, and you are able to do the complete revascularization as well as sometimes prolonged, atherectomy coronary setting. So you can do the extensive atherectomy, bifurcation, and all complex PCI with the support of Impella in those patients who are poor LV and are hemodynamically unstable. So I think this we are looking forward to a quite interesting session, and I think we can straight away go to the cases if it's good for everyone.
Excited to see the cases. I also totally agree with you. So the Impella is a great tool to bring therapy, interventional coronary therapy, which we can do to patients who need it, that you might not benefit from it if we would not have the Impella to apply it. So it's a perfect match, and I'm excited to see some cases here and to discuss this with you. Who starts with the first case?
Yeah. Cases किसके हैं उनका
I think it's Dr. Kasturi with the first case.
I thought we'll start with you because we're eager to listen to you.
Okay.
First,
Okay, we can also do that. I got a different plan, but I can totally do that. So thank you so much first for having me. So as I said earlier, I'm an interventional cardiologist. I come a bit from a heart failure background, but then made a switch to interventional cardiology years in the past, and have developed some kind of specialty in the use of MCS devices, and then naturally this standard to Impella protected PCI. And I'm happy and eager to discuss with you today the application of this technique, basically give you a rationale, and provide some guidance on how to select patients and how to do it. Although I think that you, with your ample interventional experience, will be masterfully applying this in your practice as soon as you got the device, because I really think that this benefits from experience in the interventional field, and making the transition is something which can be easily done if some things are considered. So these are my conflicts of interest. So as said before, I'll start with the short rationale, and we already had this in the beginning. What we want to do in our patients is we want to achieve a complete revascularization. We do know from past randomized trials, from the Syntax trial, that if we achieve complete revasc either by CABG or by PCI, then we do have better outcomes and very comparable outcomes between CABG and PCI as compared to those patients who are incompletely revascularized. So that's the overachieving goal in patients with any form of coronary artery disease, but especially those with complex CAD. We want to go for full revasc. And especially, or basically, we can use the syntax score to guide us there. So we want to have the residual syntax score, so what remains after PCI, to be as low as possible. And that's something we have basically shown in multiple RCTs that if we can do that, if we can achieve that, we get CABG-like results with PCI, and that's something we should strive for. And as said earlier, we have to strive for that because we see more and more patients who are not suited for CABG, who are basically surgical turn-down patients, who are then referred to us, and we have to do something. We have to deliver therapy to these patients to improve their outcomes, which is quality of life and mortality. And then we have to achieve optimal PCI results. But as you all know, these techniques we need to apply in these patients sometimes require extensive treatment, whether this would be road ablation, orbital atherectomy, or intravascular lithotripsy, bifurcation stenting, coronary imaging. All this takes time, has a certain ischemic risk because we have multiple balloon occlusions. and especially in patients with an advanced disease, this can be tricky, and the patient's tolerance to these ischemic episodes and to this prolonged treatment sometimes limits our ability to apply these treatments. And that's basically where the Impella comes to play, because this device, as easily as it's implanted by the aortic valve into the left ventricle, provides us with several meaningful effects, which we can use in the settings, because basically, due to the suction of blood from the LV and its expulsion into the aorta, what we achieve is we reduce LV pressure, we increase the aortic pressure and cardiac output, thereby improve coronary perfusion. So we basically increase the patient's ability to withstand our coronary treatment. So imagine a patient with a PCI on the last remaining vessel, and if we do extensive balloon treatment there, extensive road ablation, and those patients will definitely see hemodynamic comprise, and this will impact them on the short and on the midterm, and then also the long term, because we then tend to be a bit quicker with what we do, tend to be not as careful, not as deliberate, and the outcome worsens. Whereas if we use an Impella to protect these patients, to stabilize them during these times, we improve the outcome. And there actually is some randomized data on this topic. So this was the PROTECT 2 trial, published more than 10 years ago. This were a bit more than 400 patients that were randomized to either Impella or IABP for protection during elective PCI of highly complex lesions. And the other criterion to be included in the trial was that they either had to have an ejection fraction below 35% and the last remaining vessel, or an extensive 3-vessel disease and an ejection fraction below 30%. And what you see here is basically a clear association of the Impella treatment with lower incidence of a MACE endpoint as compared to the IBP treatment. And basically, as we know, the IBP is a mechanical placebo. So this kind of was an RCT of Impella versus the standard of care for these PCI in complexly diseased patients. However, you will also note that in the upper left corner there, you see the remark that this was the per protocol population. So these were all the patients who were actually treated per the defined protocol from the trial. And you will also note a second thing, that for the first couple of days, the MACE event was relatively low and comparable between the two arms. And I think that's something important to note, because as interventional cardiologists, even in these complexly diseased patients, most of them, we managed to basically achieve a result on the table to get them off the table and back home. This sometimes leads to us underestimating the problem of mid and long-term outcomes in these patients. But as you see below that red circle, the curves then suddenly increase and separate. So actually what happens if we do a not so good PCI in a complexly diseased patient, then he or she will have a better result after the hospital discharge, and we might not even know it. That's, I think, something which highlights the importance of these trials, the importance of a longer follow-up up to 3 months or even a year, and the importance of why we do need randomized data on that. However, the other thing is this was the per protocol analysis, because the primary outcome of the trial was actually neutral. So here you see the intention to treat analysis, the same patient, same trial, but here the confidence interval of the point estimate for the risk reduction crosses the 1. So officially, the PROTECT 2 trial was a neutral trial. However, there were some issues with the protocol deviations. So if you look at those, again, at those patients who were treated in compliance with the protocol, the trial was superior, but in the primary endpoint, intention to treat, it was not. So this has led to some discussions in the field whether we really need this. And I think Abiomed provided the correct answer of that, instead of just trying to push the debate by trying to bring reason to PROTECT 2. They basically started a much larger PROTECT 4 trial. So this trial is currently running and recruiting. It's a similar setup than PROTECT 2. So we have patients with a decreased LVEF. In the beginning, it was 40%. Now it's below 30%. They should not be acute patients, so no enzyme, no STEMI. And Then basically after careful selection in a hard team and a planned PCI, they 1,200 patients, so that's really a huge trial for these complexly diseased patients, will be randomized to either PCI plus Impella or PCI and standard of care, or but in the standard of care arm, you are also allowed to use an IVP. So I think that trial is recruiting quite well. It's running very good for such a complex, complicated, and large trial, and we will really get good outcomes of that, and really, I think, see, and I'm quite sure that it will be positive, that we will see the good effect of the Impella protected PCI. However, how we do it at the moment, how would we select, or how we do select patients in Hamburg at the moment for Impella protected PCI until the Protect 2 trial is there. So basically, oftentimes in these talks, you see this triangular, you basically see the pyramid, that it's a complex PCI is defined by either looking at the anatomy. Do you have certain features which determine the complex anatomy? Do you have certain comorbidities which are relevant, diabetes, surgical turndown, shock, valvular heart disease, etc.? And are there any equipment issues? Do you need advanced calcium modification? Do you need bifurcation stenting, etc.? And I always think, I mean, this pyramid in a way is helpful, but it's very abstract. What do we mean by that? So I brought a small case. So this is a lady I intervened on, I think it was mid of this year, and sorry, I tried to let it run again. You see here there's extensive calcification in the circumflex artery and also in the LAD. So this is basically something we have to treat with a bifurcation stenting, left main LAD and left main circumflex. And I'm pretty sure that almost all of us, almost all intervention cardiologists can in a way solve this. And most will solve this in a quick and dirty way, because this lady also had a decreased ejection fraction. She was 83 years old. EF was about 30%. She had atrial fibrillation and chronic kidney disease. So in those patients, you can get to a quick and so-called dirty solution by just doing, for example, don't do a calcium management, you don't do a rota, you don't do orbital atherectomy, you just do a provisional stenting left main to LAD, you accept some plaque shift, maybe you do a kissing balloon, but no two-stent strategy, and you achieve a result which is more or less okay, but you don't risk the hemodynamic collapse during the procedure. I think most of us can get to that point without any further equipment. However, we should ask ourselves, should we consider this a good result? Do we just want to get to a point where we have, let's say, 50, 60% good result? And I think that's not what we should do. We saw in the beginning the slides of completeness of revascularization. We do know about the importance of the, let's say, modern PCI techniques, intravascular imaging, calcium modification. So also, and especially for those patients, because remember, he's not 83-year-old with a depressed EF. This is a high-risk patient because she's 83 years and has a depressed EF. So especially in those patients with a high risk, we want to use our techniques as best as possible and as extensive as possible to achieve a good result. And this does not mean that we should stent any lesion we do see. There are different definitions of complete revasc. But I really like the definition of a reasonable complete revasc, where we basically use modern techniques, intravascular imaging, physiologic guided stenting to identify those lesions we have to treat, and then really deliberately tackling these. And if we put all this together, so a reasonable, not close-minded definition of complete revasc, using all the smart tools we have, so physiologic guidance, intravascular imaging, CTO techniques, calcium modifications, then we do know that we achieve better results in these complex disease patients. And in the current example, I then obviously decided to do some calcium modification. In that case, I like orbital atherectomy. it's always an up and down for me. Sometimes I prefer rota, sometimes I prefer that, sometimes I do shockwave. You know how it is. But I think it's important to do something in this case because the residual lumen was rather large. I thought orbital atherectomy would be a good example. And then I think the end result was okay for that case. And that's something, there was absolutely no hemodynamic compromise, just put in the Impella in the beginning. I did the treatment and it went perfectly. And I think it's important to aim for that. So we should not just aim for getting the patient off the table, but getting the patient off the table with a good coronary result. And the Impella helps us doing that. So I think I made this short table to basically put together and put against what I think what we in some situations can do as a bailout. That's the left column. What we can do, we can all eyeball lesions, we can eyeball landing zones, we can accept a bit residual calcification, friend protrusion, plaque shift, residual stenosis, and we can also accept CTOs. That's easy. That's the easy way out. But I think what we should do as advanced interventional cardiologists with a high standard, we should use physiologic assessment to assess the relevance of stenosis. And if we identify one, we should tackle it until it's resolved. We should use imaging to define the landing zones, use calcium modification as good as we can. And if a patient needs rotablation and shockwave, we should do both to get the best result. We should use definitely appropriate bifurcation techniques and appropriately sized non-compliant balloons to dilate stents and dilate stenoses. And if there's a CTO and it's a relevant vessel with ischemia, we should use advanced techniques if needed to fix the problem. But also I think the most important part is when doing so, we should not accept that there will be a short-term hemodynamic contrast, but we should avoid this because we do know, I showed you the slide earlier with the separating Kaplan-Meier curves after discharge from the hospital. We should try to avoid a hemodynamic compromise while applying these techniques. And that's only possible if you have another device which protects the patient's heart. And that's the Impella, because only the Impella CP provides him with enough cardiac output support to really cover the patient during these extensive treatment periods. And obviously, when you talk about patient selection, it matters so much if the ejection fraction is what you see here, a relatively normally moving left ventricle as compared to that. So obviously, we do not have to use Impella-protected PCI in all complexly diseased patients. That's not true, but we should consider what's, let's say, beneath the cutoff on the table. So we should consider the patient-related factors. What's the ejection fraction? What are other factors which might limit cardiac output and the patient's tolerability of the ischemic periods? And in a patient, as here on the right, where the heart is barely moving, I would always consider Impella-protected PCI, whereas here on the left, I will probably not consider it. And here, basically, I think for me, because these pyramids and most of the decision charts are not very strict on how to select patients, because you cannot really say these patients are always Impella-protected PCI patients and these patients are never protected PCI patients. But I think in general, I use this approach or these steps to decide whether I would use Impella-protected PCI. So if there's extensive 3-vessel disease, or if I'm intervening on the last remaining vessel, I will most likely go for Impella-protected PCI. Whereas if there's let's say I intervene on the LID and the RCA is relatively healthy, then that I usually go for conventional PCI. If it's a complex lesion, which is, let's say, long and calcified, then I would go for Impella-protected PCI. Preserved ejection fraction, no Impella-protected PCI, but as soon as complex lesions appear in patients with an EF below 30%, then I would opt for Impella-protected PCI. And very interesting thing is aortic valve stenosis, because obviously in patients with high-grade aortic valve stenosis, we cannot use an Impella. And this sometimes makes us believe that patients with a moderate aortic valve stenosis, they don't have a hemodynamic problem. But especially in those patients, let's say aortic valve area, something around 1.2, 1.3, in those patients, the use of a lot of contrast and long ischemic times might cause deterioration, especially if there's also aortic regurgitation. So in those patients, if I can fit the Impella in there, I try to do it. And then also something which I like to call extensive comorbidities, especially patients with CKD and ventricular arrhythmias, they increase my readiness to use an impeller. And basically, I think what's important here is if you Google this online, you will see many decision and flow charts, how to apply this and how to use Impella protected PCI. But I think in the end, all these flowcharts come down to identifying patients where you should discuss it with your colleagues or with yourself and the patient. But the decision actually needs to be very patient-centered and patient-specific, because there is no clear identifier how patients react to that. So, but everything which is on the left really prompts me to use Impella protected PCI. And if I'm somewhere in the gray zone, where, for example, I think, okay, this is a patient who has a healthy RCA, but the ejection fraction is at 30%. What I really like to do is I put in the small femoral sheath. I do all my PCIs radially. I just do the first occlusion of the LAD, let's say. And if I then see a hemodynamic contrast, so I basically test the patient, then I'll just use the femoral sheath to quickly upgrade to an impeller. So you can also use this balanced approach to this and basically test the patient a bit. But because I do know that most patients will suffer mid and long-term consequences from the hemodynamic contrast during PCI, I would be rather liberal to use Impella protected PCI approach in patients who fulfill criteria on the left, then I would be restrictive, because I do know that if something happens, it likely happens after the hospital stay or in the future, and not so much in the present, so with me at the cath lab. But obviously, there is a dark side of the moon. So we do know that if we use the impeller, there is a certain risk of bleeding, complication, ischemic complication, hemolysis, and even stroke. And this is, in a way, paired with the device because it's a relatively large device. But we can also do so many things to reduce this risk of complication, and especially to reduce the bleeding. And I think that the first thing is we do need to anticipate complications. So we do need to know if we use the impeller, if we shove it through the aortic arch, then there might be strokes. So we should monitor for that. And if we see it, we should treat it. We should always consider the possibility of infections, because we have the access of device-associated complications, hemolysis, and vascular complications. However, this is basically complications of the whole impeller spectrum, especially the impeller use in cardiogenic shock. If we talk about the impeller in complex PCI, it's mainly and almost exclusively vascular complications, because in those patients, you will rarely see device-related complications because the device is now so advanced and it's used for only a couple of hours in protected PCI that it's very unlikely that something happens there. You will barely see any infections because you only have it implanted for a couple of hours. Hemolysis is almost never a problem when the impeller is used for complex PCI, because again, the duration of usage is so low. And the stroke rate is something which really is difficult to distinguish from the impeller and the PCI access. So I think the general risk of stroke when doing complex intervention is something we have to live with, but something we really can control and which we really can act on is the vascular complications. And I think they're basically, I always say this with cheek and tongue, but there are three important things for the implantation of the impeller, which determine whether we have bleeding or ischemic complications later on. The first one is access, the second one is access, and the third one is access. It is so important to implant the impeller as perfectly as possible. So basically, that's the only important thing you can do, because if you consider that you're using, let's say, the Impella for 2 to 4 hours for protected PCI, the singular event which will have the largest impact on the patient is how you puncture the femoral artery. How well you puncture the femoral artery is the main factor which determines the outcome for the patient, because the runtime of the Impella is relatively short. So as said before, the other complications play a smaller role. So in relevance, in relation to that, the relevance of the femoral axis just increases so much. And for me, this basically means every impeller I implant for protected PCI, I do implant via ultrasound guidance, and I always do a confirmation by angiography that I really hit a good spot proximal to the bifurcation in a good area with low tortuosity. And I think this is very important. I implant all my impellers in shock and all my ECMOs in shock, even my ECMOs in eCPR situations using ultrasound. And I think there's really no argument to go against this, because sometimes when people say, okay, I do not need this. And that's true. Everybody who's doing interventional cardiology can puncture the femoral artery blindly. That's very easy. But the problem is, if you don't see where you puncture, you will never know where you got the artery. And this is so relevant because I excuse my bad drawings, but it's so important where you hit the artery. If you, I hope that you can see with me that this is the longitudinal view of the femoral artery, and you see some calcific plaques there. And if just by manually finding the artery and puncturing it, you hit one of those, that's not where you want to be. You want to be there. You basically want to puncture the artery in a spot where there's no calcification. And also, if you have the on-front view of the artery, what sometimes happens if you don't use the ultrasound, you hit the artery a bit to the side. So you're still inside, everything still works, but that's also not where you want to be. You want to be very central on top. And that's so important because this determines the closure success and how much bleeding you have during the procedure. Because if you hit the artery a bit more to the side, then in relation, the entrance into the artery will be a bit ovally shaped. There will be a bit more oozing during the procedure. If you hit the calcific plaque, you might rupture the artery by implanting the device. And if you just use ultrasound, and that costs you 2 minutes, you will hit a perfect spot. You will not have any of that. And you will also have all the options later on to do a perfect closure, because the main thing which happens with bleedings in Impella protected PCI is basically bleedings due to insufficient closure. And it's not so important which of these devices you use or that you use any of these devices, but for the patients to have, for example, the ProGlide. I personally, in Impella protected PCI, I use the ProGlide, which is not a pre-close device to apply the sutures. Then I do the Impella protected PCI, and then I do a nice closure of the puncture. You can also use the Manta. This is a bit more expensive, and you can even do a contralateral artery puncture and then block it out. The technique you use depends a bit on your skill set and the regional availability of these devices. But all these techniques become so much better if you have the perfect place to puncture the artery. And if it's a suture-based device, a plug-based device, or conventional closure, all this works better if the puncture of the artery is as perfect as possible. So this is so important to spend a couple of minutes there. And if you compare the length of time you need to do an ultrasound and to optimize the puncture of the artery, the cannulation, as compared to the oval procedure, it's really, there shouldn't be any discussion on whether we should do this or not. And this is important, as said before, because with these, I really am a fan of these explantation devices or vascular closure devices, because they achieve great efficacy and safety with these large bore vessel accesses. I think we learned so much from the TAVR operators there, and here in Hamburg we really transferred that to the MCS area. We explant all our devices with one of those closure devices at the moment. I do all of that bedside. I don't even bring the patient back to the cath lab. Obviously, for the protected PCI, the patient will still be there, but it really limits the incidence of bleedings and ischemic events by a lot. And I also think that that's the most important thing you have to do, because basically during the procedure, there's not so much you have to do with the impeller. The modern AIC, so the impeller controller consoles, they are so good that basically what you do, once you have the access and once you have the impeller sheet in there and you put the impeller in place, you basically just activate the console, and the algorithm is so good that you do not really have to care about it. So you can then fully concentrate on your PCI. There's the only thing which can happen is that if you use shockwave, you can get a slight interference with the console, but nothing which really stops the pump. So you can basically use all your techniques. You can have your full concentration on the PCI. And you really do not need to do so much with the impeller. Whereas if you remember the IBP protected PCIs, there was always that thing you might need to change the mode, you might need to think about what to do in a patient with AFib and so on. Basically for the impeller, once it's in and once it's running, the console does everything. So I think that's another reason why we should put more emphasis in impeller protected PCI once we identify the right patients on the optimal implant. And then thereafter, we can again concentrate on achieving the best PCI result for our patients. So I can already come to a conclusion here. I think the rationale for impeller protected PCI is preserving short-term safety without sacrificing long-term efficacy. So the hemodynamic support provided by the impeller allows us to optimize our PCI performance, to use all the new and modern PCI tools we have without accepting a short-term hemodynamic collapse, because we do know that the short-term hemodynamic collapse might not kill the patient right away, but it produces MACE events as soon as the patient leaves the hospital. The patient selection is obviously key to identify those who are most likely to benefit. So for me, the most important factors are the extent of coronary artery disease and left ventricular ejection fraction, because if they two come together, so extensive coronary artery disease, where I do need to use all my tools, long ischemic times, a lot of calcium magnification, plus a depressed ejection fraction below 35%. These are patients I strongly consider for impeller protection. If I'm not sure what, as said earlier, I'll just implant a small femoral sheath. I will test the patient with a balloon occlusion in the target vessel. And if I see a hemodynamic compromise, then I'll just quickly upgrade to an impeller. This takes a couple of seconds. And for me, the most important aspect when applying this technique is the implantation safety, because this basically guarantees a low risk of complications. You will never get to a point where you have no complications, but you can really minimize this as much as possible by having a meticulous image explantation using all the available tools. And I think for most of us, this is a bit jumping above our shadows, because obviously we can implant these devices quickly without any additional techniques, but we should use ultrasound, we should use angiography to really be sure this is an elective procedure, and we really need to take our time, because the access, in my opinion, is the most important part. Thank you so much, and I'm happy to answer some questions on that.
Thank you very much. I think it was a wonderful overview of protected PCI. I think these are the usual indications we commonly face and also use it in our practice as well. I think I want to ask you about the Protect PCI. The initial phase of the day 1, day 2, the Protect PCI trial did not show much of a, there was no difference in the curves. And what we were generally under the impression is most of us think that the most important protection of the Impella is during the PCI. But I think it's very important to know that the important point, I think, is to know that the complete revascularization does really make a huge difference over long term. And that is only possible with the Impella. So I just wanted to have your views on the procedural risks which can be reduced with Impella.
Yeah, it's totally true. So I really think that the caveat is that if we look at us getting the patient off the table, so to speak, to achieve any result, you do not need the impeller for that. you can get to and more or less acceptable results without it. And in the short term, this likely is comparable to a good complete revasc. But if we use the Impella, we basically buy time to do all the extensive lesion preparation we need, to apply all the techniques we need to get a good functional complete revasc, and then basically achieve for the patient a good mid and long-term result. Because if we don't have the Impella in that scenario, you will get a certain hemodynamic compromise every time you do the shockwave, the rotor, and you do know that. We always see that when the patients have discomfort when we rotablate, when they get angina or hypertension when we inflate the balloon in the left main. And this is basically like many small hits on the heart and on the other organs. And if we have the Impella, we do not get these hemodynamic compromises, which improves the outcomes of our patients. However, you're completely right. For the PROTECT 2 trial, the ITT population, the intention to treat population, was a neutral trial. I think that's why it's so good that that Abiomed is doing the PROTECT 4 trial, which will be larger and a bit, let's say, better designed, so more centers. It's not US only. It's a bit more general, and the ejection fraction cutoff is a bit more strict, because obviously the sicker the patients, the higher the expected benefit from that. But the sad truth about is that, at least here in Hamburg, and I guess for you it's similar, because we said that in the beginning, we do see more and more sick patients. So we seldomly see patients with type A stenosis and no comorbidities. We have so many patients who have a depressed ejection fraction, extensive 3-vessel disease, and we also need a solution for those patients to get them to angina relief and to get a good complete revasc result for them.
There are some questions from the group. Can you put the question, please? Are there any questions from the audience? I think there's some the chat. Dr. Mani Chabra has posted. There's a question from Dr. Ritish. Can you pose that question? Okay, if you're not able to get the question, okay, let's get going. And what is your practice in the lab? You have a reimbursement for all your cases, because that is one of the challenges we always face. And how do you balance these the cost benefit ratio?
That's obviously crucial. We are in the lucky situation that we get full reimbursement for that. We leave that if we do too much. So if I combine rod ablation with shockwave, then basically I can only get one reimbursed. But we try not to really hinge too much on that. I think it's for us, it's more important to get a good result for the patient. If this requires more techniques, we try to do that. But obviously, to get the Impella reimbursed is important, and I understand that this might be a limiting factor. Fortunately, here for us, it's not, but this obviously is a crucial part. But then also, I think we need to balance this with a decision which is good for the patient.
And I think you had given a good emphasis on the access. Yeah. And I think as a structural operator, we see so many patients who really don't have a good access. But we do so much of planning before we do a procedure. But in this kind of situation, I think it's very important to, to emphasize again that these patients should undergo a CT if it's a protected PCI, ideally a CT or ultrasound before to assess the iliacs and the femorals. I think that's a very, very important point where we can reduce the risks associated with Impella.
Yeah, that's a very good comment. I mean, I think the first thing you need to do to treat complications is to anticipate them And there are some patients where there is no perfect place to puncture the artery. But then you still need to do the procedure, but you can prepare for any bailouts thereafter. You can have a second femoral access a bit more distally or on the other side to use a blocking balloon, stuff like that. But this only works, as you said, if you know this. And I think too many people just implant the device, and then pull it out and do some manual compression, and then you know how nasty a groin hematoma is, and which can be a retroperitoneal hematoma quite quickly. So it's important to have this knowledge in advance, use ultrasound, use the CT, and do the planning, because I think these complex procedures justify a lot of planning.
And what's your average explantation time? Do you generally keep it longer, or generally you try to explant do it yearly after the PCI?
It depends a bit. So I would say in all patients we try to explant after PCI in the cath lab if it's like a real protected PCI. But as you know, and I think that's where the question is coming from, some of these patients are, let's say, in Sky Shock B. So they have a bit more than just heart failure. They are a bit more compromised. And in those patients, I then sometimes leave it in there for 24 hours and explant the next day. And then again, with these with the vascular closure devices, I don't even take them back to the cath lab. So I do this all on the ICU in the patient's bed. This works perfectly with the Manta, with the Pro Style, with all the devices.
ये और डॉक्टर रतीश का ना लास्ट मोमेंट पे नहीं कर पाए। डॉक्टर रतीश को प्राइमरी अगर कुछ तबीयत ठीक नहीं थी।
There is a question which says that for protected PCI, would you wish to get back the Impella 2.5?
Not so much, honestly. Yes, there was the advance. So basically, the Impella 2.5 was the smaller sister brother device of the CP. So it was a bit smaller, a bit less cardiac output. But I really never had the feeling that it being slightly smaller would save me from the complications. So I'd rather have the Impella CP, which is 14 French, and have more cardiac output support, because 2.5 in most cases is just not enough. So I'd rather have a bit more cardiac output support with the Impella CP in a slightly bigger device than the 2.5. What will be interesting at some point in the future, the US will probably get it next year. Outside the US, probably a year later, will be the Impella ECP, which is basically it's a version of the Impella where you have, it will probably be a 9 French axis, and then the Impella pops out. So you have a smaller axis while still getting 3.5 liters cardiac output support. This would be the perfect protected PCI device, because 9 French, that's sometimes we even have that just for aortic ablation. So that's we would consider this nowadays a smaller,
exactly,
a smaller axis, but you still get the cardiac output support. So that obviously would be perfect. But the 2.5, I think having the lower cardiac output support as a compromise would not be a good deal for me.
Yeah, ECP will really make a difference once it's available.
Yeah.
Yes. Yeah. So, there are no further questions? Thank you very much for your fantastic presentation and real overview of
Thank you so much.
Protect PCI. So I think it looks like Dr. Srinivas Kumar is ready with this presentation. So
I don't know. I'm okay to present, but I was told that Dr. Sanjeev and others.
so move the next presenter,
before me.
please. Can you move to the next one?
I can do that. So, Dr. Srinivas, yeah, am I supposed to do it? Should I share my
I don't
slide?
know. Is Dr. Atish Kumar presenting? In the thing it is written before me.
I think whoever is ready can go ahead. Whoever is ready can.
I'll do that then. I can present. There's no problem.
Yeah.
Thank you so much.
Thank you so much. If it's possible to stay for some more time and have your
Yeah,
comments,
sure.
please, we'll be very happy to.
I will stay.
Thank you.
Can you see my slide?
Yes, we can.
Yeah, I think after an excellent lecture by Dr. Benedict, I would like to share our experience of usage of Impella in cardiac shock impelling type of situations, especially in acute MI scenarios. What we generally know in India is we do see some of these patients presenting with in acute MI situations, but you have very complex anatomy. Sometimes they have left mains, and we are practicing sending such patients for surgery before. But even our surgical colleagues don't like it because it's not easy to do arrange everything in acute MI scenarios and then probably and send these patients for surgery. By the time the important time is lost and patients myocardium is damaged and they get into trouble. So that is why we, after having some bad experiences of sending acute MI ACS type of patients with complex anatomy to CABG, now we decided as far as possible, but for mechanical complications, we should try to avoid sending the patient for surgery because it has its own risks. And that's how we started using this device. And initially, when we wanted, because we were not eligible to use this in cardiac shock type of scenarios, after we became comfortable in protected PCI, then they started giving it to cardiac shock scenarios. I would share one or two case examples of this. This slide brings best wishes from Apollo Group of Hospitals. This small device, which if you see, for sake of all the seniors should excuse me, but when we look at this, it looks like a very small piece of thing. Then how is it able to do so many wonders? That's what we were thinking. And when I see and that how it is working, excuse me, slides are not moving. One minute. I'll just stop sharing and then again start. Anybody in the technical team, can you help me in this? The slide got stuck. Yeah, I think.
What happened exactly? You're not able to move the slides?
Yeah. I don't know. I'll stop sharing and then again start sharing once, please allow.
Yeah, I think that was fine.
Yeah, are you able to see it now?
Yes.
Yes, we can see.
And then when we were trying to see how to do it, this device was working like this. For sake of it is wonderful. It takes blood from here and pumps, and it ejects blood with so much. This is in vitro demonstration of people who not seen it. So much perfection the small device does and gets blood into from the LV to aorta. That's how, in spite of patients' rhythm not being well and then cardiac outputs are maintained. So this the small cartoon shows that how this small device functions so well. So then we know this sky cardiac shock scenarios, but we shouldn't be waiting till the patient goes too worse. So if you use it early, probably you will have better results. So I would show two case examples. This is a case one is an 83-year-old male, hypertensive dyslipidemic, presents with interval MI. The problem is patients presenting late. If it presents on time, then whatever type of anatomy still we could manage. But if he starts presenting late, that is because of lack of patient education, things like that, and borderline blood pressures and cardiac shock stage A to B type. Then obviously they will have complex anatomies and LV functions bad. So when you do an angiogram, it comes out with left main and triple vessel disease. Previously, you were sending these patients for surgery. Surgeons also were not willing to operate, and then these patients were dying. So what next we should do? So this is out of LV, poor LV function, interval MI. Then when we discussed, then probably we could arrange Impella in about 3 hours time, and then probably for sake of these are the standard access things. I would not go into details, but the standard teaching where you have to access femoral artery in the main before above the bifurcation, that holds good here, and that will avoid complications. Our speaker has stressed this point very well, and we became comfortable with the TAVR and other large vessel access. The same thing applies here. So after securing the good access, then probably, and then next thing is taking this wire in and positioning it like pigtail. That is quite, we are quite comfortable with the usage of it. Other thing is would be, this is a video which is recorded basically for sake of some of the, one of the speaker was not present, and they told me to show and extend it little possible.
It's actually over the wire system, thin wire which comes into the tip of the Impella device, and somewhere is the outlet port is here. So it is a rapid exchange type of system, not a run through. So we have to be careful not to remove it totally, because sometimes the lumen
Just stopped.
Got stuck. Yeah. Then anyway, that will proceed further. This is again parameter display. Many of us are familiar with it. I would skip for the sake of time. Once it is placed in, the other important thing is, as we know, that how it is placed, and you confirm its position and doing an echocardiogram properly. And once it is in place, then probably it will be more comfortable in doing complex PCIs. If you see this is the anatomy which this patient had. Obviously, interval LED is occluded, but also left main had a tight disease. And yeah, for sake of time, I've edited. Then we did crossover type of procedure in this patient, and we also this is a caudal and cranial view, so we had a good result. And once the perfusion is maintained, then patient's pressures improve, and then we could take out Impella also after a few hours. This is again, we need to be also careful and do a proper image guided technique, not to lose the left LCX. Osteum was quite good. Left main areas, what we obtained was quite good. And that's how with the OCT and Impella guidance, this patient came out. The other thing is Impella on table removal. I feel there could be slight improvement in this because now we can't pass the wire back to remove. We are all comfortable removing, though it is a soft looped catheter. While pulling it out, sometimes if the patients have some peripheral vascular disease, things like that could be leading to some sort of dissection, though it is very soft. I think we need to have some slight improvement in this to stretch it and remove it more safely. I think I request our faculty senior to comment on that further. Now you have no access, you just pull it out, and though it comes out easily like in this, but immediately after the pulling it out, you need to check whether there's any problem in the femoral axis, because sometimes it could be, but fortunately in this, it was all right. So that's how this patient, in spite of complex, this is a femoral check shot, and patient did well. So in spite of patient presenting with cardiac shock and true LMI, and we could save that patient. This is another patient, 82-year-old gentleman. If you see this, he had all the standard risk factors plus CKD. You see tight critical left main disease there. The yellow cranial view shows it very clearly. Again, surgical turn down because of MI and CKD type of scenarios. So we took the Impella support here again, and see, entire artery was diseased, but we had to use initially field XT type of wires, then multiple balloon inflations, and then probably better quality stents. Now we allow us to do a good job there. And finally, if you see, we had a good result. Entire artery was reconstructed. Then LED, caudal view and cranial view, you see that the procedure was done quite comfortably with the Impella support. The advantage of having this is you're not too much worried. It gives comfort to the operator, but I feel it is a costly comfort. But if you could do it, you can have a complete revascularization in the same sitting, and that's how the outcomes improve. and the patients do well and follow up. So this is another example where the patient did well, and this patient did not have a too much big RCA, which was occluded. This because of CKD, we had used IVUS in this patient, and initially had a lot of atheroma burden here, and the left main tight osteal disease, what you notice here, and then probably after the procedure, then you had good stent expansions, good area, and the stent starts just protruding the ostium, showing that you had a good osteal placement and the areas were quite good. So we need to get good, proper outcomes immediately and document it well. And that's how these complex patients with this support will improve. So these two cases, I thought, instead of sending them for surgery in acute stages, and then we could do complete revascularization, probably with help of Impella as well as image guidance. And in first patient, we did OCT, and second patient, because of contrast being high, we used IVUS. So with this, I thought I could invite some comments from others. What are the practice patterns? Do they still send patients of acute MI? Otherwise, most of them are in the habit of actually doing a culprit vessel and probably is planning it later, I think, in our country. But I would request more comments from my colleagues. And I also wanted to see what are the practice patterns, what is that is done in US, in their country, with Germany and others, to get more view from this on this aspect. Thank you.
Thank you, Dr. Srinivas. I think that is a fantastic show. The in vitro demonstration was really interesting to see that. And I think the important thing is to have complete revascularization. And if you have an Impella, you don't have to just only hook for the culprit artery. I think we completely agree with your. I think the aim is to have a complete, and that was again clearly showed earlier by Dr. Benedict that the long-term benefits are clearly related to the complete revascularization. I think that's one of the biggest advantages of having Impella, and one should fully make use of that. I think that is should be the important message. So I would request Dr. Benedict to give any comments, and then probably I think he has to leave for a clinical presentation. So have his comments, and then maybe thank you for your presence here today. Thank you.
And two really nice cases. I really like. I mean, you perfectly showed that basically, if you don't have the impeller, you need to be a bit quicker with your decisions. You maybe cannot do everything, and you are not as likely to achieve a good result. And I mean, we can discuss so much about, is this technique or that interventional technique the better one? And I do not really think that it's not so much is the DK crush in that scenario better than the Collot technique or this technique. It's more so, do we achieve a complete revasc result? And all these techniques, they need a bit of time, they need a bit of patience. And as you showed, especially for the OCT and the IVUS, you need a bit of time to analyze what you've seen there. And basically with the Impella, you get that. And I also do it if I have a patient, when I went through all the effort of implanting the device and already having my setup, then I try to achieve complete revasc in one sitting. So then just don't do the LRD, but do all the other lesions as well too, because I am already there. I try to save the patient from another procedure with another puncture. So I went through all the effort, then try to do basically same sitting, complete revasc. The only thing which basically limits me there sometimes is the total amount of contrast, because as you said, in some patients, when they're in a bit of an acute situation, when you do a full revasc on all three vessels, just by design, you go above 200 cc of contrast. And then sometimes let's say, save the RCA for a later day. But I usually try to get one side at least fixed. And with contrast-free OCT, you can really push those numbers down and get sometimes both sides fixed. So try to do as much as possible once you have this device in there. Totally agree.
Thank you, Dr. Benedict. Just one question, and before you leave, there is a question from Dr. M.G. Pillai. Has anyone tried transcarotid Impella in patients with diseased femorals?
I hope not. I hope nobody tried that. It's basically, I mean, everything is possible. So in theory, that should be possible. I mean, from the access, it's no problem. But I think the complication risk would, I mean, the consequence of having a complication there is just devastating. And then also the 14 French sheet in the carotid artery, at least, I mean, at minimum, I would expect that this can create some sort of a dead space where there will always be at the back end of your sheet, there's some thrombus formation. So this is an incredibly high risk of stroke. So I think this should not be recommended. I would not even consider that actually. I would rather do, if I can't do femoral, I would try to do transcaval. So basically, cross from the vena cava inferior to the aorta. I think that would be the better approach in that scenario.
Thank you very much. Thank you very much. I think he has to leave now. So thank you for your talk and
Thank
your
you.
presence.
Thank you so
Very much
much.
appreciated.
Thank you so much for having me. It's a pleasure.
Thank you,
I
Dr.
put on my
Srinivas.
email. If anybody has more questions, just shoot me an email. I'm happy to answer all the time. Really love the topic.
Yeah, Dr. Bennett,
Thank you.
nice talk. Say, I'll be finishing in next 10 minutes time. If you can stay back for 10 minutes, it would be great.
Yeah. Please go ahead.
Okay, can you share, can you see my slides, please? My slide is visible? No?
No, not yet.
Again, I'll share, yeah. Now it's visible?
Coming.
Yes, we can see your slides now.
Now we can.
Yeah. So my case is a Impella supported PCI rotablation and lithotripsy for a heavily calcified critical distal left main bifurcation in an advanced stage patient with a multiple comorbid condition. Next slide's not moving. Yeah. So my case is an 86-year-old male who's been diabetic hypertensive for 30 years and having a CKD with a creatinine hovering around 1.8 to 2 milligram per deciliter. And he presented with the recent inferior MI with the LV dysfunction, ejection fraction 30-35%, and moderate mitral regurgitation, and PA pressure 50 plus RF pressure. So moderate pH, recent MI, LV dysfunction, advanced age, and underlying CKD. He underwent angiogram, which revealed a heavily calcified critical distal left main and the left dominant circulation. And he was seen by the surgeon during heart team discussion, and CBG was turned on in view of the advanced age and multiple comorbid conditions. So we discussed about the Impella supported PCI, but the family, because they considered number of centers, surgeons, and cardiologists, they explained a very high risk. So they wanted to go for the medical follow-up, not the PCI. Meanwhile, he got admitted number of 2-3 times with the recurrent angina and the ischemic heart failure. And they used to get stabilized in 3 to 4 days time, then again got discharged. So his family was quite reluctant in getting the PCI. So last hospitalization, he presented with the compromised hemodynamics. BP was 85/50, heart rate 52, saturation dropped to 85%, and lactates were high. That time we discussed about the Impella supported PCI. Still, they wanted to go for the medical follow-up. So this was the ECG on presentation. You can see the AVR ST elevation and the global ST depression, critical of left main equivalent EKG changes. So patient was stabilized initially with the IBP support, NORAD infusion, and lactates got stabilized, ECG got better, and the family still opted for the optimal medical therapy. It was a day 6 in the CCU. So as Impella was weaned off, patient started decompensating, again dropped in the pressure, had a tachycardia, and in between he got a ischemic stroke while taking weaning from the IBP. Again, IBP was put from the opposite groin, and the neurologist was consulted. He was stabilized for next 4 to 5 days. Eventually, on day 15, discussed with the family that it's very difficult for us to take out the patient from the CCU unless we do a Impella supported PCI in such a kind of situation. Eventually, the family, they gave the consent and we proceeded. So you can see the diagnostic angiogram. This was an Impella from the right groin. It's an Impella CP, because definitely it was a left dominant circulation, very heavily calcified, distal left main bifurcation, and the calcium is encroaching upon the LAD osteoproximal and also circumflex. There was also disease in the circumflex distal calcified and the left dominant circulation. So on the next step was to, it was very difficult for imaging catheter to pass. The IVS catheter was not getting through. So started with the rotablation, initially with the left main to circumflex by the 1.5 bar, and subsequently left main to LAD with the same 1.5 bar. And the distal circumflex lesion was fixed first with a 3 into 15 millimeter stent, and subsequently throughout the procedure during rotablation with such an extensive, heavily calcified critical distal left main with an EF of 30-35% and mitral regurgitation, patient tolerated the procedure very well with the Impella CP support. Subsequently, the IVL was done because there was a heavy calcium in the osteoproximal part of the LAD and also the distal left main. So it is a 3.5 millimeter IVL balloon, and the shockwave was given all the 8 cycles of 10 pulses each in the proximal LAD to the left main and also from the circumflex proximal to the left main. And subsequently, the 4 into 16 left main to circumflex and 4 into 38 from left main to LAD with a mini crush technique. Circumflex, left main to circumflex stent was deployed and the whole assembly was taken out. Then it was crushed with the 4 into 38 DES from left main to LAD by mini crush technique. And then it was optimized with the initially with 3.5, then the 4 millimeter balloon. And the port was done left main with the 5 millimeter balloon. And the final kissing was with the 4 into 15 left main to circumflex and 375 into 15 left main to LAD. And then final port was done with the 5 millimeter NC balloon at the 20 atmosphere in the left main. And you can clearly appreciate the left main bifurcation as a very well optimized stent. And subsequently, the IVOS was done, and that clearly built well-deployed stent in left main body, and the point of confidence is quite good. You can figure of it, we can see. And everywhere the MLA was beyond the expected limit, like more than 11 in the proximal osteal LAD, and also in the left main it was 21. This is the pullback in the LAD proximal part. Is a very well deployed expanded stent. And if you compare the how calcified it was, it's very good result. And okay, I think we got stuck. So I will share it again. I need to share it again. Stop sharing.
You can proceed to next slide, I think.
Yeah. So I can proceed to the next slide. I will share it. Can you see it now? Is it visible?
Not yet.
Now?
Yeah, it's coming. Yeah. Well, first slide is seen. You can go to.
Yeah. Go to the next. Yeah. So there was slowly because get stuck. So it's IVL and then was crush. There's optimization. And then it was a very well deployed stent throughout its length. Now I'll move on. This is the final run in the both caudal and cranial views. It's a very well deployed stent, left main to ready, left main to circumflex with a mini crush, and well optimized with the 5 mm in the left main and 4 mm in the ready and circumflex proximal with the kissing below. And post PCI, patient improved very well, and within next 24 hours, Impella was weaned off, and vasopressor weaning was done by day 3, and mobilized and shifted room day 4, and discharged by day 6. On follow-up, his ejection fraction got better, and MR severity also got reduced, and his creatinine remained stable. The baseline was 1.6, 1.8, because the cardiac output improved. His renal parameters also got better, and the creatinine has come down to 1.5, and patient is doing well on follow-up for more than 1 year now. So this was the ECG when he presented with the left main equivalent changes, AVR, elevation, all the global, and the on follow-up ECG, pre-discharge ECG is very well settled your QST segments. And from learning from the cases, 86 years old, the elderly patient with a multiple comorbid condition, long-standing diabetic, hypertensive CKD, and with the LV dysfunction, EF of 30-35%, with a critical left main, with 3 vessel disease, left dominant circulation. He was deemed inoperable by the cardiac surgeons. And this complex PCI with the ROTA and IVL, and with the Impella CP support, has given a new lease of life for the patient who was very difficult to wean off from the IBP in the ICU. So started weaning, he got decompensation, got a stroke, and then again had to put an IBP, and subsequently the patient family, they gave consent and underwent PCI with the Impella CP support. It was not possible with the 2.5. Impella CP or the Impella 5 was required for this particular patient with extensive atherectomy and IVL with the left bifurcation. So meticulous planning and careful execution with the latest interventional devices and the teamwork that gives the best results in HF cases like this. Thank you very much.
Thank you, Dr. Sharma. It was a very nice case. I think it was a clear indication for Impella use. There was a very severe LV dysfunction with very significant disease where you need to do atherectomy. I think it's a very nice demonstration of a case which really requires a complex PCI in a very elderly man and a clearly inoperable patient. So I think it was a good demonstration of the indication for protected PCI. So any other comments from other moderators or any other questions?
Great case and great save, but both operator and patient needs to be lucky sometimes, because if it goes the other way, that's where we are in trouble in our hospitals. But but for that, it wouldn't have been possible. You showed it very well. And even IABP weaning, he was not tolerating, you said. And finally, revascularization, that is the strength of making the blood supply normal. How much ever anatropes you put, whatever blood pressures won't stabilize. But once the blood supply restored, then that's how LV picks up. And we have seen many times, even in RCA, inferior mice, as long as the vessel is occluded, how much ever anatropes you pump, pressures won't pick up. Once you open up, the pressures pick up. I think that's how this patient improved. And these sort of newer devices, we could save such sick patients. And, our surgeons would be also thankful, Sangat, for such, because otherwise make them operate on such sick patient. They have to stay with the patient and the bleeding, complications, all that. So our surgeons also wouldn't like to operate on such sick patients.
There is a question for you from the audience. In both cases of your cardiogenic shock, did you remove the Impella on table? What is your general practice? Do you remove the on table, or how long do you wait? That's a question.
Generally, if a patient has stabilized, as I said, once in both the cases, once the blood supply became normal, pressures improved. Then I've shown the removal also on table. But if a patient has some other problem and is not stabilized totally, we have waited up to 6 hours. But we try to get it out as soon as possible, because as long as it is there, always a worry of getting into trouble like peripheral
problem. But at the same time, don't be in a hurry to remove the Impella also. You put in a device, so make sure if you take it for another 1 or 2 days, also make sure you properly make sure the patient is very stable hemodynamically, and then make sure that otherwise, if you remove very early in some very sick patients, sometimes you lose that advantage of having the Impella.
But what I've seen, complex PCI, it's better to take out the device on table itself. But in cardiogenic shock, it depends upon, how quickly the patient takes up the pressure.
Exactly.
Because there
Absolutely.
may be a prolonged, many patients, they come late. And this stud myocardium may take 1 or 2 days to come out. I had a patient, one of my own colleagues, who had prolonged CPR outside, 15 minutes. And then after that, he was brought 2-3 hours later to me. And complete revascularization was the aim. He was in very bad shape. I think we took it out on third day, once the myocardium was recruited and he started improving hemodynamically. So it all depends upon the situation. If the patient is improving, he's come within an hour or two, and on table he starts showing improvement, then it's fine to take out. But the aim should be, take out as early as possible, but not too soon also, before it has served its purpose. Yeah.
Anyways, the question is more specific. How long you had to keep the Impella in your case is the question.
Both cases were removed on table.
Both on table? Okay, great.
Yeah.
Great.
And one more question was in the chat. Do you feel it is more beneficial in ACS and acute MI scenarios compared to stable protected PCI? That one chat question is there. It is not like that. Basically, if a acute MI has a cardiogenic type of scenario or impending shock type of scenario, that's where I think we'd benefit the most. If a chronic stable patients, even if the surgery could be done safely, but here the acute MI ACS, I feel there is more risk with surgery, and that's how I showed those examples. It's not that it is beneficial only in acute scenario. Even in chronic protected PCIs, it has shown benefit, but maybe more because in the acute scenario, surgery operating would be again more risky. That's how I wanted to stress. Not that it is useful only in acute or not in chronic.
I think if there are no further questions, we'll conclude. But the most important message, I think, is to, if you're in a cardiogenic shock, try to take the Impella early. Otherwise, that's very important to categorize the risk and decide to take it very early. And in protect PCI, I think if you have difficult complex cases, particularly a single vessel, or if you're doing atherectomy in a severe patient LV dysfunction, I think you should definitely consider Impella. And you have to definitely discuss that option with your patient, when particularly in a no option situation. If there are any other message you would like to leave, Dr. Jaiswal, my co-operator, then we'll close the session with this comments.
I think one last comment, that in case of cardiogenic shock in acute myocardial infarction, if you have to use Impella, use it before you do the PCI.
Yeah.
Because in US Pella trial also, we saw that the mortality was much less in those patients who were given Impella support before the PCI. And the complete revascularization incidence was also much more in those patients, where it was implanted before the PCI. And in cardiogenic shock, our aim is precision PCI and complete PCI. For that, I think if there is serious hemodynamic compromise, then Impella, do your complete and precision PCI. And that's the only way forward. Without complete revascularization and without precision PCI, these patients will not come out.
Yes, very rightly pointed out. It's a pre-shock condition when lactates are not very high. There is no organ compromise, like not having AKI. That is the right time to intervene.
Yes.
The second, about the protected PCI, we have a India-specific algorithm also. That is very good point scoring system based on the clinical characteristic and also the procedural characteristic. And then you sum up, and less than 3 score is less than 3, you no support. 3 to 5, you might consider support, and more than 5, you have to take LV support. And that is very good guide. That is published in Asia Intervention from our Indian algorithm.
Okay, thank you.
Let us conclude the session. Thank you, Veiva Scientific, for this wonderful scientific meet, and also all the speakers and the moderators for having this wonderful session. Thank you.
Thank you. Bye.
Thank you and good night.
Thank you so much, everyone, for joining in. And we'll see you for the next session. Have a wonderful evening ahead. Bye.